All right. My name is Okoro Samuel Shigozie, intern radiographer, Lily Warri branch. Today I'll be talking on the role of mammography in breast cancer staging and follow-up. This is the outlines to guide my presentation. Firstly, I will be giving a brief introduction, the gross anatomy, the radiologic anatomy, basis of mammography, indication for mammography and projections, mammography in breast cancer staging, mammography in preoperative planning, mammography in follow-up and surveillance. Then I'll talk on the limitations and challenges. Of course, I'll talk on recent advancements and future direction, then I'll summarize. Breast cancer is a leading cause of death among women, making early detection and accurate staging vital, very vital. Mammography is a key imaging tool for detecting tumors and assessing their extent. It helps guide treatment decision by revealing tumor size, location, and additional lesions, if any. During follow-up, mammography monitors for reoccurrence of new tumor. This presentation, therefore, highlights mammography essential role in staging and ongoing breast cancer management. So from the outline, let me talk briefly on the gross anatomy of the breast. The breast is composed mainly of glandular tissue, which is also known as the mammary glands. They are responsible for milk production, surrounded by connective tissue somas. The breast is located in the chest region or the thorax. It is more prominent or obvious in female, mostly people in pubertal age. So I'll be talking on the glandular tissue. The glandular tissues, they are modified sweat glands and they consist of 12 to 20 ducts and secretory lobules. If you look at this image here, these are the ducts. And if you look in between the trees of ducts, there are septations. These septations are known as the lobules. And each lobule consists of many alveoli drained by single lactiferous duct. If you look here, this is a lactiferous duct draining this particular alveoli. The connective tissue stroma is a supporting structure which surrounds the mammary gland. It has a fibrous and lymphatic components. The fibrous stroma condenses to form the suspensory ligaments of Cooper. These ligaments have two main functions. One, it attaches and secures the breast to the dermis and underlying pectoral fascias. Also, it separates the secretory lobules of the breast. Then talking on the pectoral fascia, the base of the breast lies on the pectoral fascia, a flat sheet of connective tissue associated with pectoralis major muscles. Because when we dissect, we all did dissection during our medical time in school. If you dissect, once you cut off the breast, you will locate muscles under it. That muscle is mainly the pectoralis major. It acts as an attachment point for suspensory ligaments. This is a layer of loose connective tissue between the breast and the pectoral. There is a layer rather of loose connective tissue between the breast and the pectoral fascia known as the retromammary space. This is the potential space often used for reconstructive plastic surgery. When I say reconstructive plastic surgery, I mean surgery done to bring back a breast to its natural symmetry after mastectomy, lumpectomy, or due to congenital anomalies. And of course, we know each organ in the body is supplied by blood. is also drained. So we'll be talking on this leads us to the vasculation of the breast. The arterial supply to the breast are from the internal thoracic artery, also known as the internal mammary artery, a branch of the subclavian artery. It supplies the medial aspects of the breast. Also, the lateral thoracic and thoracoacromial branches of the axillary artery supplies the lateral from the lateral mammary branches of the aorta and the mammary branches of the anterior intercostal artery supplies the lateral part of the breast. The breast, as we all know, has a lateral border and a medial border. So, like I said, the internal thoracic artery, which is a direct branch of the subclavian artery, if you look at the anterior tree, it supplies this medial aspect of the breast and of course, the lateral aspect of the breast is being supplied by the lateral thoracic and thoracoacromial branch, which are direct branches from axillary artery and lateral mammary branches of the aorta. Then the vein to the breast is always by the axillary and the internal thoracic veins. They are the two veins to the breast. Then the lymphatic drainage are mainly from three branches. The axillary lymph nodes, which drain 75%, the parasternal nodes, and the posterior intercostal nodes. So talking on the radiographic anatomy of the breast, you look at these images. These images explain the radiographic anatomy of the breast. There are some areas of importance we should point out in this image. There's an area we call the Shiznax boxer. This particular area here is known as the Shiznax boxer, rather, also called the retromammary boxer. It's a small fluid-filled space located behind the breast. It lies between the pectoralis major muscle fascia posteriorly, which is this. This is the pectoralis major muscle, and this is the Shiznax boxer. So I'm saying that it lies between this posteriorly, that is the pectoralis major, and the superficial fascia anteriorly. This side is the superficial fascia. This fossa contains loose connective tissues and facilitates the smooth mobility of the breast over the thoracic wall. This bursa we know is a fluid cavity. It helps breast to move freely. It serves as cushion, let me put it that way, for the breast. Then crest of duress. This crest of duress just is simply fibrous crest in the breast. If you look at this area, this fibrous gathering here forms the crest of duress. Then the corpus mamma is the body of the breast. It encompasses the central dense glandular tissue of the breast. All this we can refer them as the corpus mamma. Then this leads us to talking on the basics of mammography. On the left, there's a mammography machine there. This is a typical mammography machine most hospitals use. Looks like this. If you look very well, this is the angulation indicator scale. As it angulates, it will be showing you the angles you angulate towards. Some machines actually have this angulation indication scale around here. Then this is the tooth head. This is the face guard. Then here is the cassette holder. And on top here is the breast support where you keep the breast while doing the mammography examination. Then you use this. This is called the foot pedal. We use it to compress at times and to also release the breast. Around here, there used to be buttons here. You can also use the buttons to compress the breast. So mammography is a specialized imaging technique that uses low energy enhancing radiation, soft X-ray to see. It is used to visualize the internal structure of the breast. The fundamental principle is based on differential X-ray absorption, where cancerous tissues absorb more radiation than normal breast tissue, which enables the detection of tumors and microcalcification. It involves pressing the breast between two plates to reduce thickness, which decreases radiation dose, minimizes scatter, spreads out tissue for better visualization, and reduces motion blur for sharper images. And what are the indications and contraindications of mammography? We do mammography for breast cancer screening. Usually, we do it for women above the age of, let me say, from the age of 40. And these women are at risk. These women are known for being at risk of cancer, so we do it for them. Anybody below this range, below this age of 40, normally what we do for the person is ultrasound breast scan. And we also use it for evaluation of breast symptoms such as palpebulums, or when somebody is having breast pain, or nipple discharge, or nipple inversion. We use it as a follow-up for abnormal screening mammograms. For example, when we suspect mass or calcification. For high-risk surveillance, like a family that have a history of cancer, they'll also be going for mammogram once in a while. We also use it for post-treatment and surveillance. Somebody that have maybe that is undergoing treatment, once in a while they send the person for mammography to know the status of whatever they are trying to treat. We also use it for pre-surgical planning. Before mastectomy or before removal of any form of cancer, or before sending someone for radiotherapy, they use mammography sometimes to identify the exact location of someone they are trying to get rid of. Also, we use mammography to assess breast implants. And of course, we use it as screening in men. Example, men that have the cases of gynecomastia, that is enlarged breast in men. Palpable mass also, or nipple discharge. You can also go for this mammography examination. It's not just for women. Then contraindication, we talk about pregnancy, though it is such radiation, but it's actually contraindicated for pregnant women. Lactation, breastfeeding moms, they are not supposed to be going for mammography because breastfeeding, at the time of breastfeeding, increases breast density, which obscure lesions and reduces mammogram sensitivity. People under the age of 40 are not supposed to be going for mammography. We should prescribe ultrasound otherwise for them. Ordinary breast pain or tenderness, the person is not supposed to go for mammography. For instance, women mostly during the time of the period or ovulation, they used to have breast pain or tenderness. It does not mean they should quickly run for mammography. Then patient preparation. Mammography is somewhat a special procedure that you need to prepare. You don't just walk into the facility and tell them that you want to get the mammogram done. There are some prerequisites you're supposed to meet. There should be an appointment scheduling. They will tell you when to come. We will tell you rather to avoid deodorants or powders. Then we advise you on the kind of clothes to wear. Also, pregnancy and breastfeeding status, we check it. We explain the procedure for you. and seek your consent because it's a procedure that needs you to remove your clothes. So you definitely seek your consent. Then projections. There are two main basic projections of mammography: the coronal projection and the mediolateral projection. However, there are other supplementary projections, something like the true lateral, the mediolateral view, the lateral-medial view, the XCC, that is exaggerated craniocaudal lateral view, and the FCCM, the exaggerated craniocaudal medial view, the cleavage view, and the axillary view. And let's talk on mammography in breast cancer staging. What is cancer? Most of us, we've been hearing about the word cancer. Cancer is a disease characterized by abnormal cell in the body that grows uncontrollably and spread to other parts of the body. Normally, human cells grow, divide, and die in a regulated way. But cancer occurs when this control system breaks down, causing damage to abnormal cells, making them to multiply without stopping. These cells can form masses called tumors, which can be benign, that is non-cancerous, or malignant, which is cancerous. Malignant tumors invade nearby tissue and can spread through the blood or lymphatic system to form new tumors elsewhere. The process known as metastasis. You look at this image, we see a normal cell. Then this is a cancer cell. Then this is when it has become malignant. Histologically, we take a good look at this image as well. These two images, we see the normal communal cell. Then this is the normal squamous cells. But when it becomes cancerous, we see how it is. It grows sporadically without stop. This particular area is cancerous. Then let's talk about types and categories of cancer. Types or categories of cancers. Cancer can start in almost any part of cell in body, leading to many different cancer types based on the tissues of origin. When we talk about carcinoma, we are trying to say that the cancer originates from epithelial cells. Example of this epithelial cell is the skin and organs lining. This carcinoma occurs in 80 to 90% of all breast cancer cases. Of all cancer cases, sorry. For example, breast cancer, lung cancer, colon cancer, prostate cancer, etc. We have the sarcoma. Sarcoma, when we talk about sarcoma, we talk about cancer that originates from connective tissues or supportive tissues. For example, the bones, the muscles, and the blood vessels. We have the leukemia, that's cancer coming from blood or bone marrows. Like I said, for example, is blood cancer. And we have the lymphoma and the melanoma, which is cancer of the immune system. Here we have the lymphocytes and the plasma cells cancer. We have the central nervous system cancer. That's when we talk about central nervous system, of course, we know talking about the brain and spinal cord issues. Here we have the gliomas and the astrocytomas. What is cancer staging? Cancer staging is the process of determining and describing the size and extent or the size, extent, and spread of cancer within the body. It helps to assess how far the cancer has gone from its original site, whether it has invaded nearby tissue or lymph node, and if it has spread, that is metastasized to distant parts of the body. Therefore, staging is crucial for planning treatment, dictating prognosis, and facilitating communication among healthcare providers. The most commonly used term for cancer staging, we hear radiologists, we hear sonographers talking about the BIRAT system and the TNM system. When we did radiotherapy in school, we also heard about this. BIRAD stands for Breast Imaging Reporting and Data System. It is a standardized system developed by the American College of Radiology to classify mammography findings and guide the breast cancer diagnostic process. It is described to provide clear and consistent communication for mammogram results between radiologists and referring physicians while guiding patient management. Virus category range from 0 to 6 and correspond to increasing levels of suspicious for malignancy with specific recommendation for further action. Under category 0, that is virus 0, we say the breast imaging is inconclusive or is incomplete. Virus 0 mammogram shows questionable findings that needs more imaging. Typical image have ambiguous mass or calcification or distortion. So when a radiologist reports a mammogram as under virus 0, it means that he or she needs extra images. It's an inconclusive examination. He or she needs extra images. If you look at the image by your left, the one acquires and with cranial view, right breast. If you look at this point, circled with red, there is a somewhat hyperechoic dense lesion there. So this is questionable. It's not good enough to say that it is tumor or that it's no tumor, it is microcalcification or it's not. So in this case, the reporting radiologist will request for other imaging use. Then if you look at this image acquired, the center right breast in the lateral oblique, you will also see a somewhat hyperechoic lesion here, which could suggest or could mean so many things. So when you see this kind of thing, when the radiologist rather see this kind of thing, he or she will request for further investigations. This is classified under BIRAT 0. Then when we talk about BIRAT 1, images under BIRAT 1 considered naked. There is no abnormality. The breast tissue in such image appears normal and symmetrical, with no mass, no distortion, no suspicious calcification, or other abnormalities present. Take a look at this image on the left. This image is under BIRAT 1. There is no distortion, there is no calcification, there is nothing seen here. It's a normal breast finding or mammogram. Then BIRAT 2, under BIRAT 2 category, it represents a benign finding. This means that while these findings are present on the mammogram, they are confidently identified as non-cancerous and benign. These benign findings do not require further diagnosis workup beyond routine screening. Common findings include simple cysts, benign calcification, and scars. And if you look at this place, you see little calcifications, and if these are scars, then when we look into this place, we can see simple cysts located located at 11 o'clock part of the breast. Then BIRAT 3 is suggestive of BIRAT 3 mammogram shows lesions with less than 2% malignancy risk. Characteristic findings are circumscribed masses. If you look at this this area, especially this, is a well circumscribed mass. There's a well circumscribed mass here. It's also BIRAT 3 also show focal asymmetry. If you look at this breast image, it's not asymmetrical at all. So it needs short-term follow-up. at least every 6 to 12 months. Every 6 months, the person should come for a follow-up test. This test is just to confirm if there is change or if there is no change. Hmm? But by four in a BIRAT 4 now is broadly divided into two. We have the BIRAT 4A. In BIRAT 4A, lesions have low suspicions of malignancy, that's 2 to 10% risk. In BIRAT 4A, features include partially circumscribed mass of complex cystic lesions. You can look at this image here, this mammogram. There is a partially circumscribed mass here. It will be classified under BIRAT 4A. Then BIRAT 4B shows lesion with 10 to 50% malignancy risk. Features include irregular solid mass or suspicious calcification cluster. If you look at this place, it is irregular and it is solid more than what we are having in A. Then BIRAT 4C, a mammogram having classified under BIRAT 4C demonstrate lesion with high suspicions of cancer, 50 to 95%. If you look at this lesion, it's highly suspicious of cancer. It has irregular mass with speculated margins. Has irregular mass with speculated margins. If you look at this very well. Then we talk about BIRAT 5. This mammogram shows classic features of malignancy. Look at this. Look at the zoom view of this particular mammogram. This is malignant because it is irregular, it is speculated, it is irregular and speculated, and this is a classical example of malignant tumor. In this case, an urgent biopsy and treatment plan will be necessary, but we are advised. Then BIRAT 6 indicates biopsy proving cancer. For example, if a case of this BIRAT 5 is taken for biopsy and it is proven cancerous, it's automatically under BIRAT 6 because it has been proven. In these BIRAT 6 images, though there's none here, we will see something like biomarkers. We could see sites, we could see scars or size of biopsy image or all those things. We could see them on it in BIRAT 6. Or BIRAT 6 is biopsy proven, is cancerous. There is no two ways about it. Then another means of staging cancer is the TNM staging system. This staging system classifies cancer based on tumor size, lymph node involvement, and metastatic status, thereby informing treatment and prognosis. The T talks about the tumor size, the N talks about the lymph node involvement, and the N talks about metastasis. The T stage is most visually represented by tumor size and extent. Under T, we also have subtypes. We have the T's, that's when carcinoma in situ is highly suspicious. How do we know that carcinoma in situ is suspicious? When you see a mammogram, it will show microcalcification representing ductal carcinoma without a discrete mass. T1, when the tumor is up to 2 cm or less, and it will be well defined and visible on mammogram. T2, when the tumor is between 2 to 5 cm on mammogram. T3, when the tumor is 5 cm and above. Then to T4, when the tumor appears with extension into chest wall or skin, showing skin thickening, nipple changes or ulcerative changes. Under T, we measure the tumor size. This is not all that visible, but here the tumor size there is around 1 point something cm. and 1.something cm from what I've explained can be classified under T1. But this tumor, particularly on the right side, on the right breast, is up to 4 cm. Up to 4 cm, and when it's like this, it's classified under T3. So the N in TNN, the N is the N also have subtypes. We have NX, we have NO, we have N1, we have N2, we have N3. NX simply talks on when there is no regional when there is no regional lymph node involvement, when there is no lymph node affected by the cancerous cell. N0, sorry, NX, regional lymph node cannot be assessed. Then N0 means that there is no lymph node involvement detected. N1, metastasis to 1 to 3 axillary lymph nodes or internal mammary nodes. N2, when 4 to 9 axillary lymph node or internal mammary lymph nodes is affected. N3, when the metastasis has affected up to 10 or more axillary lymph nodes. For instance, when we look at this image here, we will see that there are about 2 axillary lymph nodes here affected. This tumor here has metastasized to about 2 axillary lymph nodes around this region. This is an ultrasound image of this same breast. The lymph node is enlarged, irregular in shape, and contains some loose echogenic tissues. Then the M in TNN, M is further classified under M0. When we say a tumor is under M0, we mean that there is no distant metastasis detected on physical examination and imaging. You have the CM0 or I plus, no distant metastasis on clinical or image evaluation, but microscopic cancer cell detected in blood or bone marrow. CM1, distant metastasis clinically or radiologically evidenced. PM1, pathologically confirmed distant metastasis by biopsy. There is a very big issue with this particular M in TNM. The issue there is that mammogram cannot fetch it out. It's not ideal. We cannot use mammography to stage this particular NATM because when we talk about metastasis, we are talking about metastasis to chest region and other organs. And mammography solitary can only visualize the breast. It cannot visualize chest and other internal organs. So it is a kind of case here. So in this case now, we use when someone has a breast cancer and we want to know if it has metastasized, it's always advisable the person gets a CT or MRI done, or any other diagnostic tool could be used to detect if it has metastasized. Mammography is not ideal for detecting metastasis. So we talk about mammography in preoperative planning. The key roles of mammography in preoperative planning includes tumor localization, extent of disease, detection of microcalcification, assessing contralateral breast, guiding biopsy and wire localization, evaluating post biopsy changes. For instance, this image here is used to detect, to localize the tumor. There's a tumor here. When we get a mammogram like this, and the radiologist looked at it, he can confidently say that the tumor is located at the upper quadrant of the breast. As you can see, there's a very big tumor here. Then when we talk about assessing contralateral breast, if for instance the left breast has a cancerous cell Mammography can help to rule out if it has metastasized to the right breast. That's why it's always good, even if the patient comes to the request that seeks for mammogram of one breast, it's always advisable to take the two views, the two breasts for comparison. Can also be used for evaluating post-biopsy changes and scars. Someone that undergone surgery or biopsy, we can use mammography to be evaluating it. Then mammography in follow-up and surveillance. It plays a crucial role in follow-up. This role includes detection of local recurrence, monitoring of contralateral breast, assessing of post-treatment changes, early identification of second cancer, guiding further biopsy and treatment, monitoring response to neoadjuvant therapy. What I mean by neoadjuvant therapy, for instance, a patient is diagnosed of breast cancer. However, surgery was requested, but before this surgery, this patient, then the doctor might send the patient for radiotherapy to know if this cancer cell can be cured without mastectomy. In this case, that radiotherapy serves as the neoadjuvant therapy because it's a form of trying to cure the thing before the main planned treatment. Mammography has a lot of limitations and it has challenges. It sometimes gives false negative results, gives false positive results. False negative, it could tell you at times that there is no lesion or that it can miss some microcalcification, and a radiologist could probably report it as normal breast finding, whereas there is something there. Then it could also give false positive at times. There's a way to highlight lymph nodes and look as if it's cancerous, whereas it is not. It has limited sensitivity to dense breast tissues. It has difficulty in detecting certain cancer types. Example, nodular cancers are diffusely growing tumors that may mimic normal tissues. So it will be always hard. It used to be hard for mammography to detect this kind of cancer accurately. There is image limitation in enhancement staging. Like I said, metastasis. You cannot use mammography to stage cancer that have metastasized in the lungs region and other part of the body. And also, there are lymph nodes that are far away from the breast. Lymph nodes that are far away, aside from axillary lymph nodes, there are lymph nodes that are very far from the breast. In case of metastasis to all those lymph nodes, especially in the thoracic region, it will be very difficult to be found on mammography. To be found using mammography. The radiation exposure, though the radiation is minimal, uses some machine uses below 30 kV, some uses 34 and below, but it's still minimal compared to what X-ray uses. However, radiation is radiation, one of the challenges. Then technical and interpretative challenges is another challenge in the use of mammography in staging. Then what can we do to improve mammography? There's when we talk about the recent advancement and future directions in mammography. So there are a few recent advancements in mammography. One of them is the digital breast tomosynthesis. Digital breast tomosynthesis. When you hear the word tomo simply means getting pictures and slides. So, for instance, our CT machine gets pictures of organ and slides. So, this digital breast tomosynthesis gets the slices of breast tissues, unlike 2D mammography or the one we do, conventional mammography. And it fetches microcalcification very early and prompt than 2D mammography. because of the tiny slices it gets while examining the breast. It also uses low dose, just like 2D mammography, almost about the same time interval, and it is best for more sensitive. It is best and more sensitive in detecting cancers in the breast tissue for screening purposes. Let's look at these images on the right. This one is the one we got from 2D mammography, our normal mammogram that we used to do. This is it. But this particular one, we use breast hemosynthesis, cutting at an angle of 50 degree. This is the definitive find we are seeing here. If you look at this, it's very, very different from this. This is suggestive of something, whereas you cannot make out anything from this. This is another mammogram. This is gotten from digital breast tomosynthesis, whereas this is normal mammography. If you look at this list, you see that there is deviation in symmetry of the normal symmetry of the breast, but here it looks as if everything is well. So it's an improvement in mammography. We also talk about contrast enhanced spectral mammography, that is CESM. In CESM, it is an advanced breast imaging technique that combines standard full field digital mammography (FFDM) with an iodinated contrast agent injected intravenously. This time around, we set the link at the vessel and inject an iodinated contrast agent. The contrast highlights area of increased blood supply associated with tumor angiogenesis. Yes, tumor is always having more blood supply. So when we normally, like I said, we inject intravenously, and as tumor per se, there will be more blood supply to it. So this contrast will of course cloud at that particular area, allowing better detection and characterization of breast lesions through lesional enhancement. It uses dual energy technique. What I mean by that is that it gets the image using a low energy. Then that image, it gets an image just like normal breast using a low energy. Then, consequent to that, high energy images will be highlighted when the iodine contrast has been injected. These two images are now recombined, then subtracted. After recombining, then it will be subtracted. The normal breast will be subtracted, then the remaining tissue will just be an image revealing lesions more clearly. For instance, this is the 2D image. When an intravenous iodinated contrast is being injected for this same person, the contrast tends to cluster here where there is tumor. When it clusters here, it shows us a classical example of tumor with enough blood supply, which is a probable malignant tumor. And another advancement is the nuclear breast imaging using Systema by, which is a type of Tecteno 99. Tecteno 99 Systemi by is a radiopharmaceutical tracer made of Tecteno bonding to Systemi by a lipophilic cationic molecule. When I say lipophilic, I mean it has love for fats. And when I say cationic, I mean it carries a positive charge. So this is, we all know about radiotherapy using Tecteno 99. When this thing is injected, into the body for diagnosis of breast cancer. It highlights, or the painting accumulates on that particular area, that has lesion, highlighting it, making it more brighter than every other body part or every other body, part of the breast. For instance, this is an image of normal mammography. Then this is when Pectin 99 has been injected. You can see how highlighted this place is, meaning that there is something going on around here. Then another advancement is multimodal artificial intelligence integration. In this case, this is actually what some of the radiologists are using now. When they get the 2D image, there's a way they used to send it to AI. AI will interpret it. AI will interpret it using algorithms. The algorithm that is particularly here is used. I think one of them is the deep learning and convolutionary neural networks. That is CNNS. It's one of the algorithms they use. An example of this CNS is ResNet 50. It will interpret and will reconstruct that particular 2D breast to show area of lesion that has lesions or calcification. This is our normal mammogram, 2D mammogram. But when it is sent to AI, especially that CNS algorithm, it will highlight it like this, this giving this thought that there is not something going on around this region. It will highlight it, even put a color there that this is an abnormal tissue. But that's how that particular one works. In summary, mammography's role in breast cancer staging is indispensable, enabling accurate tumor and other assessments, which is vital for tailored treatment and planning and improving prognosis. These are some slides I took my references, some textbook and some other things where I brought my readings from. Yes, thank you very much for your attention.